Hello, my name is Sarah Wack, and I'm a student at the University of Buffalo and the Summer Education Intern with the Jacobs Institute. I'm excited to welcome you to the second session of the Jacobs Institute's High School Webinar Series. The Jacobs Institute is a medical innovation center located in the Buffalo Niagara Medical Campus and sponsors collaboration between clinicians, researchers, engineers, and entrepreneurs to develop medical devices. In today's session, our host, Dr. Ken Snyder, will continue discussing the ever-changing world of medical practice with emphasis on new innovations that have revolutionized the field. Dr. Snyder is a dual-trained neurosurgeon and a part of the University of Buffalo's neurosurgery department. His additional training and specializations has helped given him the necessary tool set for specialization in the comprehensive management of neurovascular pathology in both the brain and spinal cord, including treatment of aneurysms and strokes. Also joining our second session as panelists is the Jacobs Institute's high school representatives, Janat and Josh. Janat is a rising junior at Public School 197 Math Science Technology Preparatory School, and Josh is a rising senior at St. Joseph's Collegiate Institute. Today's session will continue the discussion on stroke and COVID-19 as we explore the relationship between the two. As a reminder, at the conclusion of the webinar series, participants will have the opportunity to enter their name into a drawing for a chance to attend a smaller Zoom meeting with Dr. Snyder at a later date. Please remember you must attend at least 3 of the 4 sessions in order to enter the drawing. At the conclusion of today's webinar, a link will appear to another SurveyMonkey. Please fill out the survey. This feedback will continue to help us make adjustments and improvements to this webinar experience. There is also a voluntary discussion opportunity for those who wish to connect with other attendees outside the webinar series via Slack. Initially, we plan to use Yammer. However, after consideration, Slack will provide a space for participants to continue discussion and foster a community of shared interests. The SurveyMonkey link that will appear following today's webinar will include an opportunity for attendees to choose if they wish to receive a Slack invitation. Questions and comments are encouraged. Please type any questions you may have in the chat box on Zoom during the webinar. Questions will be raised when relevant during the lecture or answered during the Q&A section scheduled in today's program. Please keep all questions and comments appropriate and respectful. Without further ado, I present our wonderful host, Dr. Ken Snyder.
Thank you. Thanks, Sarah. Panelists, thank you very much. You did an amazing job last time of interrupting me and making sure I clarified issues and answered questions. A lot more of that with the session. To everyone taking an hour out of their day during the summer to spend time with us, thank you. Appreciate you all and appreciate the feedback on the first session. For those that responded with some specifics, I included my email today. Please reach out to me directly. I'm happy to answer any specific questions. There were general questions about getting into med school and life path. I will tell you this, I had no idea what I was going to do in life. I loved everything. When I did my PhD in physics, I thought for sure I was going to teach physics forever. Then I fell in love with every clinical profession I went into, and it just happened that neurosurgery was a meld of everything in all of my training. To be also honest, I think you look to the people that practice the field that you're interested in, and you say, do I see myself being one of that group? We can be in our little tribal in nature, and there's good and bad to that, but there's something to the idea of, are the people happy, right? In the field that you're picking, looking at those that practice it and spending time with them is really important. Early on in getting into medical school or beyond, don't underestimate the importance of relationships. Writing papers are important, but you're not doing it necessarily for a publication list. You're doing it to get to know the people in the field enough that they get to know you and write that letter about who you are more than what you are on just paper. And I would think about that in any experience or internship or shadowing experience you have. You're looking to see if the fit's right for you while you're trying to build the relationships with those people. Those relationships become critical. Those were a lot of the questions. Someone brought something up specific about a subarachnoid cyst. Realize that that's just a extra collection of spinal fluid in a specific area of the brain. It doesn't predispose you to anything unless it's really large. If it's really large, then the brain has a little bit more movement within the skull, and that means for major contact sports, there may be an issue. You can contact me directly offline for more specifics on it. As some feedback too, people really enjoyed the surgical videos. I've included a lot more today. I do like to, just like last week was kind of the theme of why, start with why. I think I really wanted to push myself to be more specific. Why am I doing this summer? Because I really think you all as high school students in early college have all the fundamentals already to make a significant difference. I remember one of the high school students that spent time with us learned about 3D printers and asked a really interesting question. They said, why do we have to use plastic or metals? Why can't we use the fundamental building blocks that the body uses, like collagen? And they actually, within a high school program, were moving toward building organs on a 3D model printer. You can take the x-rays of degenerated organs without cells, and what's left is the core of the sponge of its infrastructure. They took 3D models of that, made a 3D printer make it, and you can actually put living cells into that tissue. A high school student in one of our previous summers built all the foundations just for that simple principle, just by asking some basic and simple questions. My goal in each of these, ask me as simple and basic of a question as you can and get used to doing that of any of your teachers. If I can't explain it to a 3-year-old, what it really means is I don't understand it. And in thinking about it that way, it helps us all understand where the limits of the current knowledge are, or mine, so that I can continue to improve. My goal each of these sessions is for each of you to just learn one thing. And maybe, if my hope is that you get inspired enough to actually look something up on your own and start to develop your own ideas and ask specific questions. And that's what then the JI becomes the repository for, those ideas, and how can we help you blossom those unique ideas. The theme that I want to use from today actually came from a motivational speech from Denzel Washington that I thought was great. What he said is, if you're not trying hard enough unless you're failing. You're not pushing yourself hard enough unless you fail. Do not fear failure. But what I love about what he said that was unique is don't fall backwards. He said fall forward. He said don't let anybody tell you have a fallback option. You don't need a second or third option. If you fail at what you're going after, learn from it and do something else moving forward. Keep your momentum on a forward trajectory. And I love that. I love that vision. And I would have loved to have heard that lesson if I were sitting in your shoes. It's okay. It's appropriate. Just learn from your failures. So I love that. Fall forward. Follow up on some of last week. We covered and started a theme of open surgery and endovascular surgery. This involved aneurysm treatments and others, but what you were learning is there's ways of opening up the head and fixing it by looking at the aneurysm, and there's ways of going inside the blood vessels. I think what's important in that theme, and I'm going to build on that theme today on both AVMs and on stroke, is if you can't do both, you don't have the ability to modify the option for the patient. Meaning you need the skill set yourself in understanding the limitations of both to truly offer the best for the patient. Otherwise, what happens is, and that phrase of if you only have a hammer, that's all you use type of thing, but of that mindset, you will push one modality maybe beyond its limits if all you have is one modality. So whatever, again, field you go into, coming at solutions from different options will broaden your ability to solve a specific problem. Stents. We talked about stents. Stents are dumb devices. What do I mean by dumb? They are pieces of metal. They do nothing when you put them into the body. I'm going to talk about carotid disease today because what I want you to realize is when you put the stent inside a blood vessel, remember the blood vessel is living. The inside of the blood vessel grows over it. The stent ends up in the middle of the tube. It ends up in the middle of the blood vessel, completely covered up by the body, and it stays there forever. So ideas of being able to biodegrade or dissolve stents in periods of time and make them go away, implanting things onto the stent so that they serve a longer purpose. We don't fix the genetics that cause the problem. We just fix it mechanically. Maybe there's different ways we could embed things into stents. And for those that are interested and mentioned about chemistry and physics, what do you get when you take two dissimilar metals and put them into salt? When you look at the periodic table, if you take metals from two different columns and put them into salt, you make a battery. And so the people that design these stents actually have different elements from different columns of the periodic table in our body, which is a salt bath. That's a battery. We have no idea what that battery does to the blood vessels long term. So again, there's lots of opportunities for innovation and improvement. 3D printed models, we've yet to actually have someone come through here and say, well, why are we just using plastic 3D models? Why don't you actually grow endothelial cells along the inside of it? You can heat the chamber and feed it sugar, and what will actually happen is you'll build a hybrid living model. You'll be able to have an infrastructure of the vessel, but inside of it will actually be living cellular material. And I think we can ask a whole bunch of unique, interesting questions if we do that. So anyway, those were just some follow-up thoughts I wanted to plug home after our previous session. I like to reference one TED Talk that I sent you all each session. Why do I care about TED Talks? Even though I mentioned I want you guys to learn to teach yourselves, what we also need to realize, and I know this about myself, I can read a book chapter 15 times and sometimes never get the insight that a real master of the subject has. I learned this in neurosurgery. I read chapter after chapter. I thought I knew it. And then I talked to someone that did this procedure for 30 years. And what I gained out of that was I could never have appreciated what was in that chapter the way it was described to me by the master. That's who's giving TED Talks. TED Talks are often people that are the complete masters of their subject area. And what they are able to glean in 15 minutes, some of us may never have been able to get by reading the subject. But by reading the subject, we can appreciate what they're saying that much more. So again, I really like using these as tools. Anyway, I love the one on how to practice effectively. One of the things it tells us, and we're spending a lot of time talking about the blood vessels today. The blood vessels' job are to sustain the health of the tissue. All of what happens in any organ system really is in the tissue itself. For us, it's the gray matter and the white matter. The white matter is just telephone cabling, connecting the dots between the gray matter and its end function, okay? But what happens in the body is that the more you do something, the more the insulation around that electrical action or connectivity increases. And what that insulation does is it means that the fibers run faster and faster and faster. And by increasing myelination, I think that there's a lot more to that in what happens both inside the brain and external to the body in terms of automating and building multiple parallel pathways. And so it's important for us to know that doing the repeated activity, even though it may feel like we're not doing anything, we are actually connecting dots in a faster and more efficient way while we do it. When we talk about muscle memory, what we really mean is that the neural pathways are being more and more ingrained, and that myelination is getting thicker and thicker. In recovery of people from strokes and other traumas, what we're learning is that if we just electrically stimulate those pathways without even the movement, we can gain the neuromyelination. And so one thing that we're learning about in rehab that's very early on is if I can't physically do the task, can I electrically do the task and stimulate the ends of where I want and actually make that speed up repair? And we're seeing that that works. Effective practice is consistent, focused, targeted on what we don't do well and pushes the edge of our abilities. That's studying, that's anything and everything that you do. Focusing on the task at hand in today's world is so hard with all the beeps, bells, whistles, and things that go off. Really learning to put that stuff aside. The other thing that's important is don't spend hours, right? 20-minute, 30-minute sessions, take a little bit of a break, come back to it, focus 20, 30-minute sessions. These are from masters in their field that all say these, whether it's a musician, an Olympic athlete, build this type of repertoire into your study or your practice or your field. The outline I gave last time let it fall apart. I'm here for you guys. It's going to evolve however we want the discussion to actually go. I'm sorry, I'm also on call. 1 second, guys. Hey, Sid, I'm on the JA webinar. Can you take care of it for me? I'll talk to you when I'm done. All right. All right. Bye-bye. Sorry, guys, I'm on call. Thank God I finished cases right before this as well. I want to get through vascular physiology, stroke, and its treatment today. And I'm going to get to COVID because there's a lot of questions on it, a lot of things that have changed afterwards for next week's sessions. The other components, I'll be able to fit some cancer work and the other two things into the last session, okay? I wanted to pick up from where we were talking about this arterial venous malformation. And what we were talking about last time was if the blood supply from the heart came up and it had the ability to go to normal brain tissue, which remember is raging rivers to streams that are high resistance to the low pressure vein or lake, or the blood could go up to this area that had no real stenosis or resistance, these wide open malformed channels. There's no resistance here. What's going to happen is the blood's all going to go this way. And that's called shunting. Okay. And what can happen is you can actually make the normal brain ischemic because brain blood flow that's supposed to go here is all going toward this AVM. These blood vessels were not designed for raging river flow all the way through them. And so what happens is the veins dilate significantly, or the arteries start to build aneurysms. And what can happen is at some point, a weak point builds and that blows or ruptures. When we fix these endovascularly, we have to be very careful. We come up inside the blood vessel. If we go through the blood vessel and we actually use almost something like an Elmer's glue, we make it so we can see it under X-ray and we glue the blood vessels shut. Because remember, there's no brain tissue inside here. But imagine we stuck glue in here and the glue went through and glued the vein. What you would have is all of these other blood vessels flowing into this and no drainage away from it. And basically you built a bomb that will blow, and it usually blows right in front of your eyes. So the way that you fix this endovascularly is you go in one day and you glue that one shut. You go in another day and glue these two shut. You come back and glue this one shut. And then finally you glue the last two, but you stay on the raging river phase. And if you shut down all of its inflow and supply, that's how you cure that endovascularly, okay? This is what these things can look like. And the angiogram is important because it shows us something called shunting. What do I mean? You've got arteries showing up on one end, and then you've got this venous drainage structure at the same time. When you see big veins while there's arteries, you know there's a problem. The angiogram's a movie. You should normally see all the arteries at once, then all the streams or capillaries at once, then all the drainage of the vein through the veins at once. When you see draining veins, aside from the fact that something looks very wrong here, that's how you identify an AVM. This big thing right there is one of the draining veins ballooning and pouching out because it's not used to being under high pressure. Okay, this is another AVM. Again, you see this tangle, something that doesn't look like small normal blood vessels. And then here again, you see the arteries, this little tangle and this giant draining vein. That's how you know you've got a problem, some disconnect in the brain. And so based on last week, I wanted to show you what it's like to also fix these surgically. So one question for the panel. Arteries are oxygenated. They're red. Veins are deoxygenated. They're blue. Guess what color AVMs are? So in an AVM, what would happen normally? Why is the vein blue? The oxygen in normal brain is delivered through the capillaries to healthy tissue, and then it turns color, okay? Do we have any ability in a malformed AVM to deliver oxygen? Are there any normal capillaries? No. So you actually end up with a structure that looks purple. It's a mix of actually both colors. And so when you do surgery, you've got these dark veins, but when you start to get into the structure of the AVM, it actually looks purple. And one thing that we do surgically is once you disconnect it, everything turns blue again. The draining elements go from purple to blue. That's how you know you've solved the inflow problem to this tumor. The other thing is you stay outside of this AVM as much as you can. If you hit one of these blood vessels, they bleed like crazy because there's nothing in them but blood, okay? And it makes the entire surgery really difficult. And so you end up working in a plane just outside of that. And that was actually a picture of the one that I just showed you with the giant little big bleb, venous bleb. And this is what we also showed you last time, the immunofluorescence. We do this to make sure that cavity doesn't have any early drainage from within it. So that's a surgical resection of an AVM, which really involves staying outside of it and not getting into it. So my partner that just called me, Dr. Siddiqui, actually did one of the coolest things, ended up as an amazing case report, and he actually presented it nationally, globally, on a problem of how to solve a AVM in a young, maybe 20-year-old that we had no solution for. So this is a basilar artery, and it's going to this really complex, deep AVM that's draining in the veins right away. And he had a cup of coffee with one of our cardiologists. And he said, there's too many arteries to get to this thing. There's too many inflow zones. I can't shut it off. I can't get to all of them. And he said, boy, this draining vein, there's only one draining vein to this. It's so simple to get into. I wish I could just use the vein to shut this down. So let's think about what he's asking. He's saying, can I, rather than navigate all these channels, can I come from here and throw enough glue into this that I shut all the inflow zones down as well? Why do you think that's a different problem or a difficult problem to solve? What would happen if you were in this vein and tried to inject glue? Where would it go? Where's the pressure flowing right now? It flows from the heart through the raging arteries, and it flows this way. So if you were here and tried to glue, it would end up just going backwards in the vein down into the lungs and down into the heart. You need the glue to go against the raging river flowing at you, right? So what could you do? There's too many inflows. He said, I wish I could just shut the heart off for a little while. I wish I could just stop the heart from beating and stop blood flow, because if I could stop blood flow, I wouldn't have this pressure head coming back at me. Does that make sense? Well, the cardiology said, guess what? I stop the heart all the time. I put an electrical lead into the heart and I turn the heart up to beat at above 200 beats a minute. And when the heart beats that fast, it doesn't beat efficiently. There's no blood flow that flows out of it, okay? They can control, if this ever happens, VTAC or VFib in somebody on their own, they usually die, or they might die from it because they're not pumping blood. But the cardiologists that work invasively, they do this for controlled in someone while they're working on them. So on that cup of coffee, my partner said to the cardiologist, why don't we do this together? Come into the room, run the heart at 200 beats a minute. I'm going to go into the vein, which is much easier to get into. And while you're running the heart that fast and there's no blood pressure, I'm going to glue the whole thing shut. And son of a pup, it worked amazing. In 30 minutes, he cured this uncurable AVM by working together with the cardiologist. They published the case report. It had never been done before. It was just because they had a cup of coffee and shared and asked a simple question to one another. And now we think back and are like, of course, why haven't we been doing this? All right. Realize again, the simple questions, cross-discipline, are often where we see the most progress.
Dr. Snyder?
Yep.
We have a few questions about what you described. When you're talking about the veins, are the veins like very easy to see? Are they very tender to the touch?
Very easy to navigate, very easy to see. They are not thick-walled. They're built for low pressure. They're easier to tear than the thicker arteries. But when they tear, because there's hardly any pressure, there's hardly any bleeding. Things just block off on their own. So actually you can go into the jugular veins in the neck or into the veins in the leg and very easily navigate intracranially into the venous system. There's only a few turns you need to go through. It is much more complex through the arteries. The arteries are numerous through, and there's only a few draining elements of veins. So we're learning again more and more if we could use a transvenous route to solve vascular problems, there's a lot of opportunity there. And again, it's only been relatively new over the past few years.
Could you also kind of clarify, you kept mentioning the glue to like stop certain passages. Could you kind of discuss more what this glue means?
Sure. So it's literally onyx. Again, think of it like Elmer's glue. It's Elmer's glue that we put some filings into that they show up under x-ray. So if we were inside an artery, and this is really an important concept, and we have one of those little wires and tubes that we work through, we've got an open channel here. And that open channel comes down and outside the body, and we can put whatever we want through a syringe. We can inject things through it. That's how we actually visualize. We can aspirate back and take blood, okay? But one thing we can do is use a catheter with a little bit of a balloon or tube on the outside of it. And what we do is put that catheter into a blood vessel, blow up the balloon to somewhat stop the flow, and then we can inject glue forward. And that glue will fill these blood vessels and seal them for us. And then we can take that catheter out. And that permanently shuts down those two blood vessels. Now, where are these blood vessels going? They better only be going to the vascular tumor. You want to make sure you're not doing that to a normal part of the brain, or you will cause a stroke. If this blood vessel had, other branch points that were critical, and you glued it here, all of that would become ischemic. One way we do this, which is really interesting to be safe, is we put the catheter where we want to glue it with the patient awake. We then inject a drug that puts the distal part of the brain to sleep, and we do an exam. If somebody stops using their arm, we don't glue that area shut. We got to find a different route. But if they're perfectly neurologically fine when we give that little bit of drug, we know it's safe to shut it down. That's a great question. It's called Onyx. It's a really great innovation and again, lots of people have lots of interests outside of neurosurgery. These principles work in any organ system of the body. And we can selectively deliver drug. If this was a tumor, we could selectively deliver chemotherapy to those small agents. If this was a tumor, we could selectively block the blood supply going to the tumor. We do that all the time for head and neck cancers. That's what the term embolization means. Basically gluing shut a bunch of blood vessels.
And you'd want this glue to be like permanent, like you don't want
You don't want it to recanalize or open back up, exactly. Because what'll happen is over a period of days, that tissue will die off. If you open that blood supply again, the capillary beds are now dead, they're leaky, you will bleed, you'll hemorrhage into that distal tissue.
Okay. We have one last question. Are there any like physical symptoms the patient might feel if they're suffering from this?
Sure, so if it hemorrhages, and that's any aneurysm, AVM, these people show up with a massive headache. Depending on where and what's bled is where you may or may not get deficits. So when we talk about the anatomy of the brain, this can be from cancer or from other things. What's hard to predict is what the presentation will be because it depends on where the problem is in the brain. If the hemorrhage is on the left motor strip, you're going to have an inability to move your right arm or right leg. If the hemorrhage is in the left frontal lobe, you may not have anything other than some confusion. If the hemorrhage is in the brainstem, you may completely lose your arm and leg function and not be able to breathe on your own. So the symptoms from a neurologic perspective are always dependent on where the problem is. And that's what's unique about it. And when you think about how we learn this, we actually learned about the brain and its pathology from different disease states. That's how we learned what different regions of the brain do. People showed up with tumors in this region and they looked this way. So we said, that must do this. And that's unfortunately how the neurologic system works.
Thank you for the clarification.
Okay. All right, so working beyond AVM, I wanted to quickly in 5-10 minutes cover carotid disease, and then we'll finish up with stroke. So we talked about bleeds, blood vessels that rupture and bleed into the head. One important thing is what happens when something dislodges in the body and blocks a blood vessel, all right? That's what we mean by the term ischemic stroke. Ruptured blood vessels are hemorrhagic stroke. Ischemic is something blocked the blood vessel, okay? This can happen in your leg. When it happens in your heart, it's a myocardial infarction. When it happens in your brain, it's an ischemic stroke. 25% of the blockages in the brain are usually from the carotid artery. Atherosclerotic disease, as we age, takes an open vessel and starts to narrow it further and further down, both from little micro tears in the blood vessel that are there and this inflammatory deposits that build up there. What happens then is that these deposits can actually crack. And when the inside of the blood vessel is exposed to the blood going through it, the blood clots on it right away. And those clots can sit here in the neck, or they can get dislodged and thrown up to the brain. And that's what we mean by thromboemboli. And that's what most strokes are from. So how would you fix a carotid artery that's plugged up? So to the panelists, you have a common carotid artery getting 20% of the blood flow of the heart coming up to the head. You've got an internal carotid that just is this main pipe going up to the brain, and you've got an external with all these branches to the face. What do you think's the carotid lives right underneath your sternocleidomastoid muscle. It's the muscle that helps you turn your head from side to side. All you do is make a cut, doesn't matter the direction in the neck, and lift that muscle back, and right there is your carotid artery, okay? So now you're a surgeon, you're looking at the carotid artery. What do you think you want to do first? Do you want to just cut it open? No, why?
You want to get it.
It's going to bleed like crazy.
Yeah.
The carotid is under such high pressure that if you puncture it without protecting it, the blood will shoot up to the ceiling and continue to shoot up to the ceiling. So what do you think you want to do before you open it up?
Try to understand what's happening inside of the blood vessel.
So if you know from the angiogram, great question, or an ultrasound, that my stenosis is here, what would you like to do before you opened it and looked inside the blood vessel? So here's a good example of the cross section. This is often what the cross section looks like, and that's a normal blood vessel. So before you open it, you need to shut down the blood supply. And so you do that in a few sequences. You first shut down the internal carotid artery because you want to protect the brain first. You put a little clamp there. Then you come down and put a large clamp on the common carotid artery, and then you clamp off the face. The face is extremely robust. It connects the scalp all the way across. You would get good blood supply coming from the face in general filling this. You have to shut all three of them off. What's important is that you've now just shut off the blood supply to the entire carotid artery. You have to ensure that that person's other carotid artery and circle of Willis work well and are intact. Often what we do is we put an electrical grid on someone's head and make sure that the brain is staying viable with good electrical signals while I clamp this off. The other thing then is quickly. You don't want to keep that vessel occluded for a long period of time. So once you've got those three blood vessels clamped, you now cut the vessel open and you open it up looking inside of it. So you're going to basically open it right here and peel it apart. You then dissect a plane around this wall, peeling all that junk off and literally pull it out. You then sew it up from the inside out so that there aren't layers that are left there to dissect. And then what you do is you open up the external and you open up the common and you let blood wash through this out to the face for a period of time. And only after a little bit of washing that debris out do you then open up the one that goes up to the head. Does that make sense? So it's solving that mechanical problem. And this is what it looks like. So this is the common carotid artery with the clamp already around it. This is the external with multiple branches. That's how I know it's the external. And here's the internal. So now we're cutting from the common up through the plaque, up into the internal carotid artery, hoping to not puncture through to the opposite side, right? We want to stay inside the middle of the tube. And once we cut up through the middle of the tube, finding the channel, we then peel and dissect away this junk that's built up over time. Now you can imagine you're ruining the mechanical integrity and structure of this blood vessel. It's a very robust blood vessel, but you're basically ripping everything out of it except for the outer layer that still has a blood supply. And so when we're done fixing this, we sure have taken the stenosis and the plaque away, but we've left the blood vessel without the typical integrity that it usually has. And the endothelium then will grow through and grow over this section. And then what's also unbelievable is the same genetics that made this plaque form start up again. And so you can actually have a restenosis in the same segment, right? So we're basically cutting out this plaque and some healthy blood vessel, and then we sew it back up. But we do that so that somebody that had a 90% stenosis now has a less than 50% stenosis, and their stroke risk goes down dramatically. But think about how crude our solution here is, right? We haven't done anything to fix the genetics. We're basically removing a plug. And that is a asymptomatic carotid plaque. How do I know that? Because it looks yellow, okay? Then we sew that blood vessel back together, and then we open up the blood vessel the way I described to reestablish flow back up to the brain. Does that make sense? Okay. All right, so another way is, let's imagine you only had one carotid artery and you couldn't afford to have the blood vessel clamped off completely. How could you fix the same problem? So what we came up with, and actually this is what Dr. Hopkins pioneered and really became the master at, was he said, why don't I go from inside the blood vessel? I'll put up a little balloon, a little filter. It's an umbrella basically with like a spider web on it. It's to catch debris. It allows flow to keep going through it, but it acts as a basket to catch any garbage that might break off. And once you have an endovascular railroad track and a filter, you can now bring a stent up and open it into this region. Does that make sense? And so that's how we do and why we might do stenting. So you think about which one do you want to do? Do you want to stent or do you want to do an open surgery? You do whichever one is best for the patient. If somebody's had a lot of radiation surgery to the neck, it's very hard to do surgery through the scar. Stenting is perfect. We used to try and do open surgery on people where the problem was up under the jaw. We'd have to dislocate the jaw to get to the area. Now we can just go in with the stent. It's much easier. All right. On the other hand, there are times where the stent doesn't work. You've got your blood vessels can become very tortuous with high blood pressure in time. And so if you had a roller coaster of a carotid artery, it's very hard to navigate that from inside the blood vessel. Whereas it's a piece of cake to just open up the skin and there's the carotid artery and you can fix it. So they're actually complementary tools and you can use them complementary. This is what a stenting procedure looks like. We record every single surgery that we do. And the reason we do it is to improve. Sometimes the surgeries go a certain way that I think in my mind, but then when I actually watch me perform, I'm like, what was I thinking? And so it's really important, I think, as we self-improve to do this, to have this tool. We record every single case we do. And in fact, we've made 2 major video series of our teaching components of our cases that we put out through the Congress of Neurosurgery. And so learning from this type of constant ability to self-reflect, I think is great for, again, whatever field you go into. So here's an angiogram, and you see how this becomes very narrow right here? That's the area that we're trying to fix. And so we go up with wires and tubes. Let's see if we can get a good picture. Here we go. So this has got the distal basket in place, and you see this long structure right there? That's the stent. And so what's going to happen in a minute is you're going to see us start to twist open this stent. Do you see the stent opening up? That's the stent pushing on that narrow structure over that long region.
Not to allow the
Good.
stent to move forward.
Perfect. And you see how there's still a little bit of a waist right there? Doesn't need to be perfect. It just needs to be covering the area where the stenosis was at. It is. See how we move up and down along this wire? All the tools move in and out along the railroad track. We then go into that stent where it's still a little bit narrow, and we squeeze it open. Again, these are very simple tools that we use, balloons and stents and little coils, and that's what we use. But again, let's think about what we've done. I'll keep moving through this. Again, the goal was to open up the blood vessel to minimize the stroke. You'll see that we did it. See how this area is wide open now? All right, so we fixed the stenosis. But let's think about what we didn't do. Over the period of 4 weeks, the body's going to grow over the stent, and the same genetics that caused atherosclerosis begin again. Dr. Snyder, this is the 3rd time in 5 years that you need to fix my carotid artery. What's wrong? Can't you get this right? No, the tools that I'm using aren't fixing it for you forever. Stop smoking, stop eating and doing all the other things. And even with that, every person in your family's died from a stroke because of athero. You've got the genetics for this. So all I'm doing is routine maintenance of squeezing the blood vessel open to keep somebody from having a stroke. We need to figure out how to improve the genetics of what's happening in the endothelium to start really improving these fields. Does that make sense? This is what a plaque looks like when it's a hot plaque, when it's a ruptured plaque, when someone came in with a mini stroke. Do you see the difference? It's not that yellow anymore. It's blood. There's fresh blood in the wall of the blood vessel. And so it's not surprising that something can break off from this and go up to the brain and cause a stroke, right? So what was very interesting to us is that we were doing these stenting procedures on people, and sometimes within 24 hours, people were showing up with a new stroke. They actually had developed a stroke after we stented the blood vessel. Well, the more we looked at this, and the more we looked at a chicken wire mesh stent, the more we said, how on earth is a chicken wire mesh going to stop that from giving us a problem? When you squeeze a stent into that, something's got to squeeze through it, and that could be what dislodges. So to solve that problem, we actually put an ultrasound into the blood vessels after we did stents, and look what we started to see. This is a spherical ultrasound. The wires are stents. Look at that. That's just some goober that came through the stent and is sitting, flapping in the breeze of the carotid artery, waiting to break off to go up into the head, right? And so we quickly identified the reasons why there were minor strokes after carotid stenting procedure. And we realized we have to look for those things. And if these are the typical stents we use for the carotid, we've evolved to start thinking about these types of stents. Use a much finer mesh so that you don't have the debris going through the stent tines. Does that make sense? The other thing, and this will be the final topic before we finish up with some stroke imaging, is knowing both techniques, open neck surgery and endovascular surgery, allowed us to do the coolest trial I've ever done, which is a hybrid technique of both. What we did was we did a direct carotid surgery just to be able to put the tube in to do the endovascular procedure. And we shut off the flow in the neck and reversed it through a pump and put the blood back in somebody's leg after going through a filter. So we took the blood supply that normally would be going up to the head and we reversed it. So we were actually drawing blood from the head down. So if anything ever broke off, it was going to go out of the body. And so in doing this, so what we did here is, here's the incision literally is 1 finger breadth. We wrap a loop around the carotid artery and we stick a tube in it. We then have the tube come back to a pump and a filter and put the blood back in the leg. So there's hardly any blood loss. We then go right through this and put the stent in place. But the blood is flowing this way if there's a problem. This surgery had the lowest complication rate of any carotid trial ever performed and the lowest risk of stroke or any event in any trial. It was so much fun. But having both tools is what allowed us to do this. Are any quick questions before I spend 15 minutes on stroke?
We have just a few different questions. We have some questions on the plaque, like what causes the plaque? Is the plaque like liquid sometimes? How does it build up? So just more information on plaque.
Sure, great questions. So within the wall itself, what happens is you start to get these micro tears and blood goes into the wall of the blood vessel and there's this fresh clot. As the body degrades the clot and inflammatory cells come in, this becomes a fibrous cap. And then what can happen over time again is a little rupture and blood rushes in and you get another jump. So what happens in carotid stenosis is it doesn't go like 5, 15, 20% blocked, 30% blocked, 40%. It goes from nothing to 50% blocked. And then the body calms it down and there's a crack and blood rushes in and then it jumps up higher. And so these happen because cholesterol and other deposits change the elasticity of this blood vessel and you can start to get cracks into the wall of it. And again, atherosclerosis is a great thing to look up and learn about because it happens throughout the entire body. Another way to think about things is this. We've come up with incredible solutions to keep our body alive a lot longer than it was supposed to be alive. I mean, look at the life expectancy even a couple hundred years ago, okay? We've come up with other organs. We've come up with ways of bypassing other organs. We have yet to come up with a way of fixing the blood vessel. What are the number 1 and number 2 killers of the world? Heart disease and stroke. Both are related to the same exact problem, atherosclerosis. Both are the same exact issue, plaque buildup or problems that rupture and cause heart attacks or strokes in the head. We, again, to come back to, if we want to revolutionize, again, our even life expectancy, the next phase is what can we do about the underlying vascular system to allow it to heal itself and sustain itself? Those are great questions.
Thank you for the clarification.
All right, I'm going to move in 10 minutes and cover some complex topics that we can talk about more either offline or into the next session, but are the key to what we've done to revolutionize stroke. The first part of this is a 33-year-old woman that I treated as a fellow 15 years ago maybe, and it's why I treat stroke. She was 9 hours out from an event, and remember that if you were beyond a certain time from a stopwatch, you weren't offered any treatment. And she had a full occlusion of her basilar artery. So she was actually at a major center in another city, and they told her, I'm sorry, we can't do anything to help you. The family knew that we were doing pioneering research in Buffalo, and they actually flew her to us. So imagine all of the time that could have passed between that. And we still elected to treat her, and we rebuilt her basilar artery. Now, the basilar artery sits in the brainstem, connecting the brain to the body. The carotid arteries would be filling, so the frontal lobes are working, so you have an awareness and are thinking. The basilar artery isn't working. That's your spinal cord and brainstem, so you can't move your arms, you can't move your legs, you can't blink. She remembers everything. We call it a locked-in stroke because you're locked inside your body. You have an awareness, but you can't move anything. So she remembers nothing could be done to help her. Coming to Buffalo, we re-stent and rebuild her entire basilar artery because at that time, Dr. Hopkins wasn't thinking about, let me remove clots. What he was thinking was, let me just stent clots against the wall and get them out of the way so I could reestablish blood supply, just like we do in the carotid artery. And so she was one of the first in our stenting for stroke trials that we did after we learned what the cardiologists were doing. And in the first week in the ICU, she still wasn't moving everything, but she started to get a flicker of movement in her fingers. And this is her at 6 months.
My name is Passenger Cedar. I had a stroke in November. I just want to say thank you very much, Dr. Levy, for all your help and not giving up.
Not kidding.
Not giving up on me.
And how is it going? How are you feeling?
I feel great.
Now, obviously, you're able to talk very clearly, and
I'm getting my speech back little by little.
Dr. Levy's the chairman of the department. He was who was teaching me when I was a fellow. This doesn't happen when you follow or wait for the literature to tell you what to do. This happens when you are the ones writing the literature. No one would have touched her. The risk in the literature says she should never have recovered from the stroke. All it takes are a few patients like this for you to realize we're not doing this right. There's something more out there. And so at 2 years, you can't even tell that she's had a deficit. So this is what really drove my passion of pushing. There's a lot out there that we don't know about stroke, and we've got to find a better way to do it. So if this is your carotid artery, and this is your internal cerebral going to your brain, and this over here is your middle cerebral going to the lateral part of your brain, and we happen to have a blood clot here. What we did in that original trial was we went in and stented those open. We basically went through that and plastered the plaque against the wall. The problem was people had to be on aspirin and Plavix, big blood thinners, because the metal of the stent would have clotted. What we've evolved to now is, can I put a stent in there that's attached to a stick so that I actually use the stent almost like a fishing device? So what we do is, again, it's just glorified plumbing. We go into the neck with a big tube. We go up with a wire. I make the wire into a J because when I push the wire through the clot, I don't want it to poke out through a blood vessel. Does that make sense? So I put the J on it to make it so that it's protected as I push through. I then push this wire through the clot and then bring up this little tube. Once I do that, I'm able to bring up a stent on a stick and cover this whole region. That stent gives me flow through this segment. And then when I'm ready, I blow up a balloon here to shut down blood supply, and I pull the whole thing out. And what comes out is chunks of thrombus on the stent. And that's called a stent retriever. And so this is what that looks like. So if we're doing I'll show you about the perfusion in a minute. These are the tubes going up into the carotid artery on the left. Here is crossing this with a jade wire. You can't see it, but there you go. See how the wire is bent onto itself? That's so that it doesn't puncture through a blood vessel. Realize you can't see anything beyond the clot. Dye only goes up to where the blockage is. So everything beyond the blockage is blind to you. So you don't know whether you've ruptured a blood vessel or not. So it's by feel and it's by location. And then what we do is once we pull the wire out, we do an injection through the little tube, praying that it's inside a blood vessel. Because if we see a puff of smoke, we know that we've ruptured a blood vessel, okay? Again, most of the time these patients would be dead anyway if we don't do what we're doing, right? So these are life-saving procedures. You see how I see blood vessels here? That's a good sign. That means the tube is in a blood vessel distal to the blockage. Then what we're doing here is bringing up the stent that's wrapped onto itself to come out of the tube. And so what you're going to see in a minute is that we push the stent forward and pull the tube back, and that lets the stent open up and expand through the region of where the clot is, which is right around that segment. Let me keep moving through. So right now, here we go. We're letting the stent go out and pulling that small microcatheter back. And so you see those little struts of the stent through this region right here? There's little wisps of a stent from here to there, if you guys can see it. That's where the stent is pushing the clot against the wall. So the next thing we do is we try and go up and lodge the proximal part of the stent. And then in a minute, we're going to actually blow up a balloon and pull everything out of the head, hoping that the clot is trapped into this stent like a fishing net.
Dr. Snyder?
Yeah.
You mentioned the shape is like that J shape to try to avoid hitting the blood vessels, but what happens if is it still possible to pierce a blood vessel even with the J shape?
Not usually with the J. You can rupture a whole segment, but not usually with the J. The J really protects you. We learned that the hard way. By having it like a finger or a point, I don't care how soft the point is, if you put a rigid structure right behind it, you make it a harpoon. Here we're pulling the entire structure out. Did you see that? And then in this final run, you'll see that we've restored blood supply to that part of the brain. And so that's what surgical thrombectomy procedures are like. Here's where all the innovation comes. How do you know the brain tissue is alive or dead before you do that procedure? We've gotten really good at pulling the clots out. The question becomes, if that clot was sitting there for a long enough period of time that the distal part of the brain died off and you opened it up, somebody's not going to improve. The brain tissue is already dead. It's a futile recanalization. And sometimes it becomes so ischemic, it actually hemorrhages right before your eyes. So the question becomes, is there anything that we can do to tell if the brain tissue is alive or not before we elect to take somebody for that surgery? And that's where all the innovation of the past 10 years came in. And it basically came in by realizing that we could do one thing. I'm skipping a lot of imaging and getting right to the meat. We got this really cool $2 million scanner from Toshiba that looks at the entire head in one revolution. There's only 20 of them in the world, and we have 3 of them in here alone. One of them just for animal research. And what that scanner allowed me to do was inject dye into the heart, up into the head, and do 20 pictures of the head in 1 minute while blood was flowing through the arteries to the capillaries and to the veins. And by looking at the blood through those areas, I could figure out whether the brain tissue was alive or dead. So we take these 20 pictures, and you see how these areas of the brain light up like this? Those are the blood vessels. But what's also happening, not just in the arteries, is if you take any voxel of brain tissue, little capillary beds are also lighting up that tissue. Does that make sense? Mm-hmm. I mentioned before that the brain's got the ability to dilate or constrict capillaries when it needs blood. And so what we hypothesized to find was that if a portion of the brain is starving for oxygen, it could dilate out its capillaries to actually pull more blood into the region of need. And that's exactly what the brain does. And when the brain can't pull any, that's when it starts to die off. So if we could make a picture of the volume of blood in an area, we could actually assess whether it's alive or dead. So if you looked over the minute and looked at the flow of contrast into a region, you'd see that it peaks and then it comes back down. The area under that curve is its blood volume. Really simple math, okay? By doing that calculation in every single voxel of brain, we make pictures. And those pictures tell us if the brain is alive or dead. And what happens here is the blood volume tells the whole story. If you have a blockage and you have more blood than the other side of the brain, and think about this, you have more blood on the side of your stroke than you do on the normal hemisphere. Well, why is that? The normal hemisphere capillaries are nice and tight. The stroke capillaries are wide, so there's more blood volume inside of them. Does that make sense? And as you cannot sustain that anymore, this is when the tissue starts to click off and die off. So if someone shows up with a picture that looks like this, there's nothing I can do to help them. If somebody shows up with a picture like this, they go to surgery every time. I don't care what the story is. It could have been a stroke from 3 days ago. Their brain tissue is still alive. I'm going up to take the clot out. It's literally that simple. I will begin next time's session with 3 quick cases of the pictures of what that looked like for the decision making, and then we'll jump into COVID. Any follow-up? I know I went to time, but any quick questions to follow up?
There's just one new question. What you mentioned the dye that kind of helps guide you through. What is the dye made out of?
It's iodine, and we wish we could come up with a better agent. Right now, the dyes stay inside the blood vessels. That's like watching the boats go up to a factory and making an assumption whether the factory is still working or not, whether or not the boats stopped going there. We want something that could diffuse into the factory to tell us what's happening in the factory, because we're making an assumption that the dye not getting to a region means that it's dead. That isn't always true. We need a diffusible tracer that would show up under X-ray. We don't have such a thing.
Does the dye have like any harmful effects to the patient?
It can cause kidney problems because everything you put in has got to get flushed out through the kidneys. And so what you need to do, if I can find my glasses, what we need to do, is get something that you put into the body that flushes out through the kidney that doesn't cause potential kidney issues. But the reason that I don't usually worry is I'm making a decision between viability of brain tissue and whether or not there could be a kidney problem. You can always end up on dialysis or even a short period of time. We can't do that for the brain. But again, another great question. Imagine you could come up with a dye that didn't give us the toxicity of the kidney. It would revolutionize how we practice.
Thank you so much, Dr. Snyder, for our second session. Reminder to fill out the Survey Monkey that will appear after this, and that we have 2 more sessions next week.
Great.
Thank you
Sorry to
so
run
much,
late.
though.
Thanks, everybody. Have a great day.
Have a nice night.